represent the Center for Medicinal Cannabis Research at University of California. I'm the medical director. I'm also the director of HIV psychiatry for UCSD. So I have this Venn diagram that actually very nicely overlaps in the context of cannabis. So half my world is cannabis, half is HIV, but there's so much overlap. And it's actually HIV that got me into the cannabis research game. I actually moved most of my talk to really focus on HIV here for this audience. And I didn't want to get into the politics of things. And Lord knows I cannot predict what's going to happen in my country at all. So I didn't want to make any predictions about cannabis either. Anyway, I did take out some things like related to immunology and some of the interesting findings there. I know we're going to talk about that later. And Tom, my colleague, is going to talk about cognition. So with all that, let me get started. I don't have any disclosures. We're going to focus on epidemiology and then really look at the treatment cascade in HIV and how cannabis fits in there, and then focus on some of the clinical trials that have been done in patients with HIV that relate to medicinal cannabis. Okay, so cannabis, as you guys know, is a plant that has been around for millennia. It's been used for medical purposes and for recreational purposes. Earliest reports of its use are from China 3,000 years ago, and your own Queen Victoria was prescribed cannabis for migraine headaches back in the 1800s. So worldwide, 2.5% to 5% people are using cannabis. In Canada, it's about 12%, 12-month prevalence. In US, it's 15%. In the US, we've noticed that things are probably increasing. The prevalence is increasing. We think it's in part due to the liberalization of cannabis use laws. And also there's actually a decrease in the perception of harm or risk related to cannabis use that is probably also influencing people's likelihood of using. When you look at HIV, this is the data I've been able to collect from various sources. And it's all kind of a hodgepodge, but bear with me. There's, about in the past month, if you ask folks with HIV, at least U.S. veterans, about 15% will have said they've used cannabis at least once in the past month. And then 3-month prevalence, which we get from HIV clinics throughout the United States, it's about 24%. 12-month prevalence is it's between 33 and 43%. There's actually data from Canada that 43% of people with HIV in the past month have used cannabis. And then lifetime prevalence, at least in the United States amongst patients living with HIV, is about 62%. So a lot of exposure to cannabis out there in the HIV space. Some interesting demographics from some of these studies. Affects every age group. It's probably more men than women, and it's probably more folks who identify as LGBT, well, at least LGB, than people who identify as straight. There is, with use, there's lots of ways of trying to characterize use out there. Did you use once? Are you using every day? Are you using it in a way that is contributing to dependence or an unhealthy pattern of use? And cannabis use disorder, cannabis dependence, seems to affect 9 to 10% of regular users of cannabis. It's something that does have a negative impact on their quality of life, their ability to function. So it's something to pay attention to. There aren't any medically assisted treatments, so there's no medication, at least there's nothing established quite yet in the literature where you could prescribe something to help people stop using cannabis in the setting of cannabis dependence. They do have some psychosocial treatments. Some of the goals of psychosocial treatments may be to reduce use. It may not be to eliminate use. Interestingly, the only kind of treatment study that I saw that really affected HIV in the literature was a study that looked at espert and the effect of espert on reducing the hazardous or the amount of use or hazardous use among persons who are using. Espert is screening, behavioral intervention, and referral to treatment. So it's a brief way of kind of getting a sense of are people using a substance is it causing them harm, and can you give them some brief tips about reducing harm and get them to treatment? Well, that didn't actually have any effect on the people who were using cannabis in this study, but it did actually have, this aspirate did actually have an effect in reducing the hazardous use for other substances that were being talked about. Anyway, the prevalence of cannabis use disorder is estimated to be quite high in persons with HIV. 31% of people with HIV in our kind of some of these academic centers throughout the country were estimated to have a cannabis use disorder. It was about 49% of the people who actually admitted to cannabis use. It was such an interesting study. It was the only one out there. It's hard to imagine that that's the case, but some of the other substance use disorders do seem a little bit seem okay. Certainly where we are, there's a lot of methamphetamine use, and I know that we're one of these sites here. You see, I participate in a number of these scenic studies where these studies are done. But in any event, there's wide regional prevalence. So basically, depending on where you are, there's more or less cannabis around. I think part of the problem here is that so many people with HIV are using cannabis for both. Will admit to using it for physical symptoms, for medical purposes, but also admit to say, like, yeah, I don't mind getting some psychoactive benefit from it as well. So they don't mind if it relaxes them. They don't mind a little bit of the high either. And it may actually be that some of our ways of capturing cannabis use disorder are going to be insensitive to the fact that people are using cannabis for multiple reasons. But it's certainly very common amongst people with HIV to use it for both medical and recreational purposes, and it's more so in HIV than HIV negative cannabis users. So this is from London. People, again, showing the overlap between how people are using it, cannabis, excuse me, both to get high and also to treat some of their symptoms. This group also asked people with HIV why they were using cannabis. And these folks reported that a lot of things actually got a lot better when they were using cannabis. Their appetite, pain, nausea, anxiety, depression, a lot of things that seem very consistent with neuropathy and neuropathic pain. Some other things got better, including headaches, so just like Queen Victoria. And then they said some things that they thought would get better but actually got worse, not surprisingly, were things like memory loss and their speech, which they noted to be more slurred if they were using. Interesting study, but one clinic, but really this is kind of the universe out there. A lot of people in the United States, a lot of people in the medical profession have trouble rationalizing this, the fact that people can both be using something for medical purposes and like the fact that it relaxes them and or even appreciate the kind of psychoactive high that they get. And I think that this is the best way to kind of give people a rubric to help them to relax about how many of their patients are using cannabis. But there's different impact of any type of substance use. I mean, people can go out and have a drink and enjoy that socially. Does not mean you're an alcoholic or have an alcohol use disorder. I don't know of too many medical reasons for drinking, but certainly for cannabis, we'll get to that. There's certainly some. Just in general, though, if it's having a positive impact on your life, whether it be in relieving symptoms or by giving you a chance to relax, relieving stress, then there is I think a value for it in promoting health. I mean, our job as doctors are not just to fix problems, but to really promote health, and cannabis may fit into that calculation for a lot of people. Certainly, there's a potential for a negative impact, and that would be a cannabis use disorder, cannabis dependence, and that might be a different calculation you'd have to make if you're a physician and you kind of see that becoming relevant. And there are plenty of people who are using cannabis where they're at a party and they're just using it, and it has no impact on their life, and I'm not going to get too upset about that either. Okay, so that was quite fast. I'm sorry, I actually noticed myself talking fast. In any event, our kind of summary of that first bit was that people with HIV are probably using cannabis at higher rates than the general population. And although they have higher rates of cannabis use disorder, which is likely, I don't know exactly how the fact that a lot of times there's a mix of medical and recreational purposes underlying their use is affecting that. So it's an open research question. Anyway, the real kind of impact of cannabis, at least its negative impact, in the public health space would be how does cannabis really affect the HIV continuum of care. And I understand many of you are HIV providers or in the HIV space, so many of you are probably familiar with the cascade of care, continuum of care, 90-90-90, those types of things. And so basically, you want people who have HIV to know that they have HIV infection, to get referred to treatment, to start on antiretrovirals, to be retained in care, to become virally suppressed, and to live just as long as anyone else in their community. That's basically the goal. And we have noticed that with each step we either do okay or not so okay in folks with HIV. And we have to figure out what are the barriers to getting people to viral suppression and long and healthy lives. This is outside of the scope of the National Academies report. National Academies of Sciences in the United States actually reviewed the literature on cannabis and calculated all the evidence out there for cannabis use-associated harms. And they put it up, they made a very nice summary of all the literature and science. I have the reference for it at the end of my talk, so you'll be able to see that. It's free and you can download it online, but these are some of the different cannabis-associated harms. Again, they don't really talk about kind of HIV-related stuff. That's what I wanted to review here. I broke it up into kind of infection or transmission risk, linkage and retention, adherence and viral suppression, morbidity and mortality. I didn't really see anything about the HIV testing and testing rates, but that doesn't mean it isn't out there. I just really didn't see it in my review of the literature. A lot of this data actually comes from Canada. I don't really separate I remember some of it coming from Canada. I don't really separate between Canada and the United States. Until the border is shut down or threatened to shut down. I treat you guys, I don't see much difference. In any event, I think some of this comes from Vancouver, actually. There's a really good group looking at at-risk youth. And they found actually a lot of evidence that cannabis use might be protective in some ways and reducing risk factors for HIV transmission, like delaying time to injection drug use, or interesting one where people who were using cannabis actually were more likely to be retained in medically assisted treatment or opiate agonist therapy. So if you had like a heroin use disorder. Not from Canada, from a lab, but they gave people THC, and it turns out it's not a aphrodisiac. So people who actually got THC compared to a placebo felt less likely felt less interested in engaging in risky sex. They thought it wouldn't be a good idea, and they weren't likely to do it. They didn't have the lab was not set up to allow that to happen. It was just like a kind of a self-report while they were feeling that after they had smoked. But in any event, so it's not like doesn't seem to be anything inherent about cannabis that would promote risky sex. However, when you look kind of at observational studies, and you see lots of different studies, lots of different groups where cannabis use is associated with risk behaviors, you do find an association. But most of the authors will admit that they feel like a lot of that is more of a kind of a confounder. So basically, the people who are more likely to appreciate pleasure, people who have pleasure on their mind, or have more of a hedonistic propensity. And this is their words, not really mine, but in any event, they're more kind of pleasure seekers. They may not be interested in condoms, and they may be more likely to smoke cannabis. So it's not like cannabis is actually driving transmission risk in that population. It's just kind of it's a fact that a lot of cannabis users, they may be mavericks, they may be, and therefore don't feel like condoms have much value to them, or they may be more susceptible to peer pressure and have lower self-efficacy, which would also then influence interpersonal dynamics in the context of negotiating sex and condom use in sex. So all these things probably speak to the fact that cannabis is just something that may be incidentally found in these studies as related to transmission risk. Now, if you look at the biological stuff, there are a couple interesting studies out there. This is probably the one study that might broadly relate to immunology that I'm going to show you. So I think there is a laser pointer. So people who were daily or more cannabis users, when they showed up for their initial viral load after being tested for HIV, actually had lower viral loads than people who were less than daily. And there's some evidence of immunological impact of cannabis, which may in fact impact viral load. And I'm making a leap here in saying if you have a lower viral load, you're actually less likely to transmit HIV. In this case, I'm not sure it's significant at all, but it's interesting. And then the other study that's interesting, and I wish there were a figure I could show, because it's kind of like it was just kind of out there. This is in Clinical Infectious Diseases, by the way, which is a good journal. But they asked people, they were looking at viral shedding in semen of people who were virally suppressed, so people who were with HIV who were virally suppressed. And they asked a questionnaire, like the night before you gave your sample, did you smoke marijuana? And it actually among the things that were significantly associated with viral shedding in the semen samples of these patients was the self-report of cannabis use the previous night. I don't know how to explain it. That's all they did. They just reported it. It's a very interesting finding, but so anyway, that's that. Now, linkage and retention, there doesn't seem to be much of an association between cannabis use and either linkage to care or retention. So, I always worry a lot of substance use or serious mental illness is actually going to make it less likely for people to get care. They'll be less likely to be referred appropriately for care and less likely to show up to their appointments. But cannabis use doesn't seem to have an impact on that. And the only study that found an impact also said that people who were using cannabis and had trouble getting to care were also binging alcohol. And although there was a study that looked at missed clinic visits, there are two studies that looked at retention in care, did not find an association between cannabis use and retention in care, or continuing to come to appointments. There are many studies out there. I don't think I actually captured them all. Many studies looking at adherence in cannabis use, and really there's hardly any association between cannabis use and adherence to antiretroviral medication. There's probably, I have to probably give you a caveat. So if you look at a high-risk group of youth, cannabis use among them, a high-risk group where we're already having a lot of trouble with retention and adherence, and really kind of figuring out how to make HIV treatment, make an HIV treatment program that works for them. Cannabis use was associated with poorer adherence, so it might just be identifying a higher risk group among a high risk group than any particular impact of cannabis use specifically. And then there is the one study that looked at cannabis dependence in HIV, and they found in the broader population of cannabis users, there was no association between cannabis use and poorer adherence. But in the cannabis dependent folks, among those folks actually did have poorer adherence. Here is actually a controlled study where people were brought into the hospital and given where they were smoking either active cannabis or placebo cannabis, and they looked at the impact on antiretroviral levels. So there's some in vitro evidence that there should be kind of boosting of antiretroviral levels because of inhibition of some of the cytochrome P450 enzymes. But actually, when they brought these people in the lab, they found for unfinavir, no effect on plasma concentrations, but for indinavir, which is a protease inhibitor, nofenavir and indinavir, there was a significant reduction in plasma concentrations of that antiretroviral as a result of, we presume, smoking cannabis. And whereas it was a significant reduction, they did not feel that it was a clinically meaningful reduction to actually have affected the potency or the ability of that medication to work. And if you look at viral suppression, which is really the kind of thing that you would want to use as your kind of measure of effectiveness of an antiretroviral treatment, studies are mixed, but for the most part, it doesn't seem like there's much of an association between cannabis use and lower rates of viral suppression. So, maybe with cannabis dependence, you'll have some poorer adherence, as we have demonstrated, and ergo some higher rates of higher viral loads. But for a lot of the other studies, it really didn't show much of an association between cannabis use and poorer rates of viral suppression. This was also a lab study. There was no impact, short-term exposure to cannabis and CD4 counts. And this is actually a really great study. There's an old study that looked pretty hard at cannabis use, and there was no association between cannabis use and progression to AIDS, so positive or negative. However, there may be actually some slight mortality benefit to cannabis, although the authors did not present it that way. They just said there was no association between cannabis use and mortality risk in these violin plots. This is compared to other substances that people were using. So essentially, the kind of the proof is in the pudding. So if you're worried about cannabis use and its overall impact on people's health, I think this is a really valuable study compared to other drugs. It really doesn't have end up reducing or shortening people's lives. And in fact, kind of the way I read this, it may actually have had a slight benefit. But I admit this type of research is a little out of my wheelhouse. Anyway, in summary, this is for part 2. Cannabis use has some association with HIV transmission risk factors. This is probably just incidental and mediated by other factors. There's a possible association with poorer adherence and poorer viral suppression, especially in the setting of dependence and maybe in the context of some really at-risk groups. And this may again be maybe a function of a problematic use of substance and maybe a artifact of other kind of factors that just kind of make these folks more vulnerable. Unlike other drugs, there's no association with mortality. There's a big caveat on all of this literature because it's observational in nature. It really it uses like existing sources that weren't really designed to test questions related to cannabis and cannabis use more broadly. But it's the best data we have, and generally I think it's pretty good. Okay, so there are a number of clinical trials out there. And I wanted to spend the last part of my talk talking about those, especially the ones that affect people with HIV. Guys probably know this, but it's worth really distinguishing between the three types of cannabinoids out there. Cannabinoids, so I have a broader talk about how cannabinoids are just one of the constituents of cannabis. There's lots of other components in cannabis, terpenes, flavonoids, and more. We don't know why cannabis has had such an effect as it does, because there are so many compounds that people get exposed to when they are actually consuming it. The majority of the literature is focused on cannabinoids, and probably because of THC, which was found years ago to be the psychoactive, one of the major psychoactive component of cannabis. But it led to discoveries that our own body has its own endogenous cannabinoid system, and I'll talk a little bit about that. The two major endogenous cannabinoids are anandamide and 2-AG. The phytocannabinoids are the plant-derived cannabinoids, but probably what we're talking about mostly here. And the two big ones are THC, tetrahydrocannabinol, and CBD, or cannabidiol. Cannabidiol, increasingly touted as a cure-all for just about anything that ails you. And then I do want to make a point about synthetics. So you guys are probably seeing synthetic cannabinoid use. And generally, the term has really bad baggage these days, and rightfully so. Many of these synthetics are being formulated. They're being kind of made in clandestine labs, and they're really impure, and they've got all these different, really high potency for the cannabinoid receptor. People are ending up in hospitals after being exposed to them. Classically, it's K2 and spice, but they've got a lot of different names. In many contexts, they're technically not illegal because the government doesn't even know about them, and they've just been made. So they get into people, so you can see them get into communities and cause outbreaks of cannabinoid intoxications. And so a lot of different research papers have kind of covered that story. Well, dronabinol, marinol is also a synthetic, okay? So if you're, and they're making synthetics CBD as well. So you might see synthetic attached to a cannabinoid. It doesn't necessarily mean it's a street synthetic. So I just want to kind of make that distinction for everybody. So the endocannabinoid system is actually really fascinating. There's two receptors, cannabinoid receptor, cannabinoid receptor 1 and 2, or CB1 and CB2. The kind of basic understanding is, at least in the brain, it kind of slows things down when things get overexcited. And it does it with this really interesting kind of, it's part of this kind of feedback loop. So if you get excitation down a presynaptic neuron, you get release of neurotransmitter, stimulation of the postsynaptic neuron, which then actually causes or stimulates the production of our endogenous cannabinoids, which then are released and feed back to the cannabinoid receptor, in this case CB1, and hyperpolarize the presynaptic side, thus slowing down neurotransmitter release. Okay, that's my medical kind of colleague version of it. But I'm happy to kind of break it down some more if people have trouble or want to kind of get more of a sense of how it happens. Essentially, it just kind of chills things out if it gets too much. And there's important reasons for that sometimes, because we don't need to have a lot of excitement around. And it may be that a lot of excitement around causes inflammation and free radical formation and things like that, which actually can be damaging to neurons. In fact, this is these are the proposed kind of functions of the endocannabinoid system here. So it's supposed to promote relaxation, eating, sleeping, protection like neuroprotection, and forgetting. I mean, we forget that forgetting is actually an important process. There's a lot of stuff we don't want to keep in our brains, and that might be what. And if you kind of think about all these things, what are people using cannabis for? And what are some of the seemingly oddball things that people want to use cannabis for, like PTSD? Well, interesting, that forgetting could play a role there. Relaxation also play a role there. So any number of different conditions might actually have a big endocannabinoid role. So I usually want audience participation for this part of the talk. So can somebody kind of give me, throw out at least one thing that they noticed that is interesting about this slide and the picture?
Eli Lilly.
Eli Lilly. I heard 1913. Good. What else? The obvious one. It has cannabis.
Tested.
Physiologically tested, yes. Cannabis sativa, American grown, sorry guys. And then the thing that I just want to point out here, analgesic, hypnotic, antispasmodic, and powerful narcotic, okay? So all this thing, 1913. We'll get back to that. Anyway, so there was 1913, and then that, actually Sherry nicely presented, there was this big gap happened in the United States too. All these laws which made it impossible, took cannabis out of the doctor's office and put it on the kind of the naughty list, the illegal list. And you know, right now we're playing catch up, and many of the reasons why cannabis is even back in the kind of medical sphere is actually because people with HIV who reported benefits for it and advocated for its use. And it dovetailed nicely with the kind of the scientific discoveries, which allowed us to really think, oh gosh, maybe there is something to this whole cannabis thing. And that includes discovery of these receptors, the identification of the, the chemical structure of THC, and then a lot of other things that we know can influence or modulate the endocannabinoid system. The story of the Center for Medicinal Cannabis Research at the University of California is wrapped right up in that history. So basically, California was the first state to pass medical marijuana legislation. It was in 1996, and then 3 years later, the legislature was like, well, we need to know if marijuana actually is doing anything. And so they passed another law which formed the Center for Medicinal Cannabis Research, or the CMCR. And they funded the original CMCR studies, which I'll present to you, many of which included people with HIV. Anyway, the other kind of laws are more relevant to California, but now we have legalized recreational use of marijuana, and the tax revenue from the legalization of recreational marijuana use. Some of that tax revenue is actually going back to the CMCR to basically fund additional cannabis research. These are the completed studies from the first round of CMCR. Some of them are not technically from the first round of CMCR, but part of the CMCR kind of umbrella. As you can see, we kind of biased toward randomized controlled trials, which usually meant using placebo cannabis. All of them used plant material from cannabis that was supplied by the government, the US government, the National Institute on Drug Abuse. And it was in a variety of conditions, mostly pain-related conditions. We had one study of multiple sclerosis and spasticity. But as you can see, the two studies of HIV neuropathy and HIV neuropathic pain. And these are folks who had very little luck with other medications on the market that are traditionally prescribed for neuropathic pain. This is actually the study that happened in San Diego. Crossover design, so you were either randomized to receive cannabis first or the placebo cannabis. And in this crossover trial for both groups, there was about a 30% reduction in pain intensity related to cannabis use compared to placebo. Interestingly, we talk a lot about the placebo effect where in cannabis trials, when they asked people who were getting placebo whether or not they thought they were on the active drug, half of them thought they were actually getting active cannabis. When they were switched to the real cannabis, 100% of them knew they were getting the real cannabis at that point. Anyway, this is a kind of a replication study, but it was the other study, HIV neuropathy, that happened, and again, a 30% reduction in pain related to cannabis compared to placebo in people with difficult to treat, treatment-resistant HIV neuropathic pain. This is another study which actually looks at kind of dosing. Most of those dosing studies in cannabis actually dosed to tolerability, not necessarily to effect. And so this is actually my mentor, Barth Wilsley, who just retired. He actually did this study where he did an original study where he gave people 7% THC and 3.5% THC cannabis. And he found that people got just as much pain relief from 3.5% as they did from 7%. So he tried to push it even lower. And he gave them 3.5% and 1.29% THC. And he found that they were also equally analgesic. So he found that it was that you didn't have to dose very high to get a nice benefit from cannabis. He couldn't say whether or not this was, from the THC itself or from the other constituents of the cannabis plant. But he did demonstrate that it actually had much fewer side effects related to the lower dose, including perception of being high, which was interesting. So you could get the medical benefit without necessarily getting the psychoactive effects, or the acutely psychoactive effects, the intoxicating effects. Overall, we've made efforts to try and put this in perspective. So if you compare the benefit from medicinal cannabis to other common treatments for neuropathic pain like gabapentin, basically the number needed to treat is about the same. So basically 1 out of every 3 people will benefit from cannabis, just the same for gabapentin, which is probably one of the most commonly prescribed substances. This work hasn't been redone to look at duloxetine and the SNRIs, which seem to have a more favorable NNT with neuropathic pain. But we was working with a medical student who was taking a class on cost effectiveness analysis, and so we actually, it's kind of a Frankenstein's monster of exploratory cost effectiveness analyses, but generally speaking, we found that we used a model of treating neuropathic pain that had duloxetine, gabapentin, and other common treatments. And we decided to see what was the impact of adding cannabis to these regimens. Can we get additional benefit that people might be willing to pay for? And we used the studies, data from the studies at the CMCR, including Dr. Ellis's UCSD HIV neuropathy study, to kind of model the efficacy of cannabis. We used the COMPASS study, which actually took place in Canada, to model adverse events. And we put different economic values on these different model inputs. And then through the cost effectiveness analysis, determined that maybe not starting people on cannabis when they come in with neuropathic pain is the most cost effective approach. But if they fail their first treatment, then we found that what was the most cost effective was adding cannabis to the second round. So give them another treatment, say they were on duloxetine first and they go on gabapentin, but if you add cannabis to the gabapentin, they're actually probably going to experience a benefit that they'd be willing to pay for, even if they have to pay out of pocket for their cannabis. In general, the best source of information about the effects of cannabis is the COMPASS study, long-term, because they followed people for a year. In the short-term studies of the CMCR, people generally had mild side effects that were often very temporary and not inconsistent with other medications that are commonly prescribed. These are not CMCR studies, but they are clinical trials that involved HIV. Cannabis helps people with HIV sleep. There was a objective measure of sleep in this study, which failed. So they unfortunately were not able they couldn't actually talk about that data, but subjectively they were able to demonstrate at least a perceived benefit of cannabis for sleep in these folks. And then obviously cannabis dronabinol has an indication for HIV/AIDS wasting syndrome. Certainly cannabis helps with people with HIV gain weight. And interestingly, the weight gain was in the people who actually had low body mass to begin with, not necessarily normal body mass. So, a lot of times insurance companies will actually require you well, in the United States, to prove dronabinol, you have to usually demonstrate some kind of low body weight. And there's some evidence to support that decision because dronabinol can actually help in that setting. So this is the National Academy of Sciences, as well as they documented all the harms associated with cannabis and the evidence for the harms. They also documented a lot of the benefits as well. And as you can see, people with HIV have contributed a great deal to our understanding about the benefits of medicinal cannabis, including for chronic pain, for sleep, and then of course for weight gain and appetite in the setting of HIV and AIDS wasting. CMCR also contributed to the kind of spasticity findings, which the National Academy of Sciences thought there was great evidence to support a benefit of cannabis. So if you look at 1913 and you think about how cannabis was touted as an analgesic, antispasmodic, and hypnotic, today we have good evidence that it is good for chronic pain, spasticity, and multiple sclerosis, and sleep. So we have come full circle. And where do we have to go? I think we need to do a better job of in our observational studies of trying to disentangle the medical use with the recreational use, and pay attention to dependence because it might help kind of really contextualize a lot of the findings. But we really want to do more clinical trials. We want to have better placebos so we can actually answer a lot of nagging questions about that. And currently we don't have great placebos, especially when we're talking about smoking cannabis or vaporizing it. In the US, we want to kind of change the law around cannabis because we want to get to the point where a doctor can prescribe it, where they actually know what they're giving somebody, they know how much to give them, and they know that it's going to work. And then I think a lot of the other studies that the CMCR is doing, and here's a list of the current trials that are funded. So only 3 of them are active right now, but one of them that's active is actually Dr. Henry's study of HIV neuropathy, where we're looking at cannabidiol mostly, or cannabidiol heavy preparations of cannabis. We want to kind of look at all these other potential outcomes too related to cannabis use. Here's stem cells that differentiated into neurons and kind of organize into these little organelles. And so we're going to do some studies where see how CBD or THC can influence the organization of these brain balls. And then we're looking at cognitive outcomes, behavioral outcomes, hormone and immune responses, systemic and CNS endocannabinoid, dopaminergic function. It's actually in healthy control. The CNS studies are in healthy controls of people with bipolar disorder. And then, of course, we're kind of interested in just all the pharmacology, the entourage effect, trying to understand that. There's so much out there, and it takes a lot of work and a lot of people. So here are some resources. I can go back to this, but I do want to say that these are the people, many of the people involved at UCSD. Anyway, I think there's always room for cross-border collaboration, even if I can't bring cannabis back and forth very easily. So thank you very much.